acute form is called laryngeal tracheobronchitis. It's a viral condition. And this is the one that we commonly see in the children or the child looks acutely ill. So they have edema, especially edema on the airway is very dangerous. Destruction of the respiratory cilia, that hair that lines your respiratory system. They have even phlegms, the exudates. The usual barking cough, stridor is there. So if you really sit in your boards and you see croup, it's automatic. You would hear the brassy cough and the stridor, and difficulty breathing, the orthopnea. When these babies are having difficulty breathing, they cry, and that makes the cycle even worse because crying worsens the symptoms and they become hypoxic. Of course, later on you look for cyanosis. That could be a very dangerous sign. To compensate, the heart will always try to beat faster. So you'll have tachycardia. Worst case scenario, they stop breathing from the laryngeal edema. We should have a trach set available, just in case of emergency. Anybody seen the boards, by the way, about laryngeal problem, laryngeal swelling, laryngeal obstruction? It's automatic for nurses. We have to have trach set available, right? We don't have to put it on the test. It should be in the back of our heads. We should have a trach set available already. Okay, so for treatment on page 582, increase the humidity. If you have a portable humidifier, you can buy it from Walgreens. I actually want to get one for myself, just to make it easier for breathing, I guess. She has one, I know. Oh, I thought you were pointing at a humidifier. Okay. Or I put a star here because I see this a lot in still being tested, being asked in the boards. We take the child to the bathroom and run the hot shower, the hot water in the shower. We don't give them a shower. We just run the water. Hot one to form the mists so that they inhale it. And it's the reason why we do it is, remember in the previous page we say it's happening almost at night. I mean, usually at night. So we teach a mom they don't have to go to the ER immediately at night, especially at night. Just turn on the hot faucet and hopefully the breathing gets better. They get better in the morning anyway, right? Unless, of course, they stop breathing and they're cyanotic, you call 911. But if it's just a brassy cough and difficulty breathing, try this step first before going to the ER or calling 911. Or you could use the nebulizer approved or prescribed. Or if you have a mist tent, this is in the hospital usually, or a croupette, which is croup, which is a tent that looks like this. Right? So this child is very limpy, right? I mean, even look at the reflexes. It's a very weak child. Look at the foot or the feet. If you're sleeping, your feet are not even like this. Your feet usually will be up. But so very limpy child. This is like a maternity premature child, right? And but nowadays, what they ask in the board exam, how will you provide emotional, psychological, tactile support for this child? You can actually be inside the tent. Nowadays, they have a bigger crib, and the moms are usually allowed to sleep inside the crib. We see that a lot in pediatric units. Another question in the board, since this is a child of, 5 years old maybe, and then they always ask for play, right? Play as a part of growth and development. So how can you still, how can you still provide the opportunity for the child to play and for the growth and development? How can he play? Let's granting he's awake right now, but he cannot leave the tent. What can we do here? Peekaboo? Sure. At least, right? That's what they do. Yeah, that's a good answer, actually. But recently came out in the boards, and the question was, the parents were bringing toys for the child, and the question in the boards is what kind of toys would be allowed inside the tent. And it's a very good question, and it's a very easy answer. The boards is so easy. As long as it's something that does not get wet. So stuffed toys, teddy bears, not allowed. Why? Because the mist is moist inside. And if it's moist, it gathers the bacteria and it becomes moldy. So you can put the plastic ones, the soft plastics. And you would think, yeah, the boards asked that. We don't see that in the book. That's where teachers come in and discussion comes in. Because they don't really say it particularly, but you will see it in the board exam. So, having said that, let's put something here. When they're on a mist or a tent, let's not forget growth and development. I always say, I have said it so many times yesterday. Go back to chapters 15 to 20. You need to know the developmental stage for this child. They will be playing. What kind of toys? They cannot go out of the mist. So they have to have something they can play on. Inside. And what kind of toys? Something that doesn't get wet. Sorry? Legos. Yeah, anything that, of course, we don't want them to swallow or choke on it. Anything that doesn't get. I'm just sharing with you that the one that came out in the board was the teddy bear, which should not be allowed. The stuffed toys. Okay, so this is the mom who can be inside the tent. That's on page 582. Second paragraph, first and second paragraph, you have laryngeal spasm, and you'll see the mist, the croupette there. Yeah. All right. Other nursing management, IV fluids definitely. Place the child on the CRM, cardiorespiratory monitor, and monitor vital signs. Needless to say, oxygen and O2 sats will be monitored. Another thing in respi in children, we don't want to give opiates, morphine sulfates. We know that it depresses the respiratory system, right? So no narcotics, you depress respirations, no sedatives. Look at this child. I mean, it's a no-brainer. Are you going to give him morphine? Are you going to give him sedatives? Excuse me. Hello. I don't think so. Right? Giovanni, agree? Right. We give this child epinephrine. Epinephrine is a bronchodilator. So to nebulizer, he's awake. Also, steroids. Maybe I'll just put it here, but I don't need it till probably close to lunch. Set up na lang later. Just come back. Thank you. So that's your croup. Croup, the first one. Under the... What is it? Croup, right? Croup syndromes. Benign and B, you have epiglottitis. So the epiglottis. Why? You okay? What? You okay? Alright. You okay? Okay, epiglottis now. We are now on the swelling of the tissues now above the vocal cords. Definitely it's now in the throat part. So our complication, we watch for total obstruction. This is a favorite in the board exam. I like epiglottitis because you can already almost always kind of like when they put it in the story, you already know what they're going to ask about. Because they're only, if you notice here in your book, it's like one side. There's about 4 paragraphs about epiglottitis, so it should be very easy. So this is caused by the HIV virus. So that's why we had to immunize the children, right? In term 3, we did immunization. Remember? So this is caused by the influenza virus. Common in 3 to 6 years old. It's rapid, it's progressive, it's life-threatening because it's the vocal, it's in the throat, and the complication is total obstruction. So definitely it's life-threatening. It's a medical emergency. We don't dilly-dally. We don't play around with it. We treat it immediately. So what's happening? What's the manifestation? It's abrupt. Yeah, we look at the labs. WBCs may be high, but if I sit on my boards, I will probably not remember that. But I will definitely remember the child is drooling. She is having difficulty breathing. She sits up and leans forward, like our cardio patient in myocarditis, pericarditis, they lean forward. But she is drooling and she is having difficulty swallowing here because it's the vocal cords here. It's on the throat. So they appear wide-like, anxious, and restless. That's a sign of low oxygenation. They're gasping for air. And they have, again, the first one was a dog. This one is a frog. Frog-like croaking sound on inspiration. Both of them, really, A and B, are just like difficulty breathing and a blockage of the air going into the throat. But epiglottitis has no cough. So they're drooling, they have a lot of saliva, but there's no coughing. Right? But when they breathe, it sounds like something is blocking the airway, but at least they're not coughing. And our problem here, again, is the edema. Do you look at their throat? Look at your throat with a flashlight or a pen light. It's beefy red. It's raw. It's still red, but never put anything inside into the back of the throat because it could cause more wrong spelling wrong. Laryngospasm. So, board favorite, never do a throat exam on a baby with epiglottitis. It can cause laryngospasm. Another board favorite, these babies, they have a weird sound when they breathe, but they're not coughing, and you will see that they're drooling. Do you remember in our lecture in maternity, you better, I was your teacher? Do you remember that we said babies don't usually drool? They don't have salivas and they don't have tears and for the first 3 months. So if you see this in a child who is a 1-month-old baby and they have drooling, that's a pathologic sign, right? It's a sign that something's happening because we said in maternity they should not be drooling at all. Right? So we can combine information when we sit on our boards. Bring it on. We know what they're talking about. Right? So that is our classic. Those are our classic signs. So we look for the treatment. Anybody who has difficulty breathing, it's automatic. Bam, we put the trach set at the bedside. Yeah, we put oxygens, O2 sats, monitors, apnea monitors. We do antibiotics. Although we said this is caused by a virus, right? But as a secondary infection, they could have a bacterial infection. So we be ready with the antibiotics. But antibiotics is not the cure for epiglottitis, right? Because epiglottitis is caused by influenza virus. So it should be antiviral medications. For prevention, they would ask in the boards, this is your HIV vaccination of 2 months. Okay, on page 583, RSV. This is another. Another board favorite is the RSV. Respiratory syncytial viral disease. So yes, for those who are asking, bronchitis, bronchiolitis, they're not included. But it's also not in your notes, right? So, okay, unless I missed something here. So RSV in the bottom. Just briefly, because this is usually done by RN, so we're just going to take care of the patient as an assistant to the RN. So we just need a little bit of information, what's the viral disease about, and then what do we do as precautions. So, what? This is responsible for a lot of cases in bronchiolitis in infants and young children. The most common cause of viral pneumonia is your RSV. So when you see there are lots of pneumonias in the hospital, you have the bacterial pneumonia and the viral pneumonia. So this one is the main cause of viral pneumonia. It's the single most important pathogen in infancy, meaning it's the most common occurrence in respiratory-wise. They survive up to 6 hours. The virus will survive up to 6 hours. And it's common in winter months. And here is the trick. But when we see this in the board exam, we know already it's a trick. Why do I call it a trick? It's a respiratory condition, right? Yet it's spread via direct contact. So it doesn't get spread by inhalation, droplets, respiratory. So this is one kind of virus that it says it attacks the respiratory system, but it's spread via contact route. So virus to the skin, virus to your face, but it goes to the direct contact. It's not airborne. It's board favorite. It's automatic. I'm not going to sit in the boards and spend 2 minutes just to analyze it. When it's very clear, it says contact precaution. I'm not going to get, there's a trick. It should be respiratory precaution. There's no trick. Okay, this is not airborne. This is not respiratory route. This is direct contact. Of course, since it's respiratory system that's affected, we don't want to be smoking or inhaling gas, kerosene, gasoline, or whatever, because it's your respiratory tract that's affected. Even, I don't know, who are still using wood-burning stoves? Dirty kitchen, anybody? Yeah, it'll be good when you cook your, when you go to Yosemite Park and you want to cook outside. Okay, but still, it happens. So our assessment, we examine nasopharyngeal washings. In simple English, we're going to get a sample of your nose, from the nose, phlegm, whatever, dripping thing there from your nose. And we you know what's the curette, right? Curette? It's like in a tube, and then it's a long Q-tip with a cotton in the tip, and then you get a sample for it. It's culture sensitivity. That's a curette, and you put it in the thingy, in the long tube, and then you break the bottom. If there's a bottom in the thingy, right? In the tube. Well, I said curette. Nobody knows curette, so I have to say thingy. See, everybody understands thingy. So that's the nasopharyngeal washing. That's a nicer way of saying it. So that's our diagnosis. So we get that sample from the nose or the throat, and then they put it under a microscope and see if there is an RSV. So the treatment, standard isolation precautions, because we don't need respiratory, right? This is spread to the rectum. We can still use mask, even if they're not spread through droplet route, but because they may have a secondary infection. They could, because this is a respiratory disease. Gloves and gown, more important. Of course, frequent hand washing. Another board favorite, you would notice in the ones in highlighted. Why liquid soap dispenser? Why not? Because it's right there. That's why if you ever use a soap, use it yourself. We don't share. I don't share, unless of course I know the person. I share the bar soap. You always want to use liquid body wash or liquid whatever, right? We don't want this even outside, especially in restaurants. Never. You? Okay. Symptomatic treatment. If they have a cough, treat the cough. If they have a fever, treat the fever. O2 sat should be about 90-95. There's no perfect things such as 100% all the time. They're sick in the hospital. 95 is fine with me. Right? Suction the patient. Intravenous fluids. These are common respiratory management. Monitor INO, Pedialyte, and Rice Lights are electrolyte drinks.
Right.
Yeah. So electrolyte drinks high in potassium and sodium. So we can do that as replacement. Okay, another treatment, a board favorite. Bronchodilators and steroids are not helpful because this is a viral infection. Right? So we go straight to the antiviral meds, which are the board favorites. You have the ribavirin. Okay, fine. Ribavirin. Let's just say Virazole. Is that better? Virazole. This one, we sit in the boards. I don't know. I had fun studying for the board exam because when I sat for my boards, it's like, I know this already. I read this somewhere. Because I read a lot. That's why. Because you can anticipate. If you've been reading reviewers so many times, you know already what they're going to ask about RSV, you know ribavirin is there, and you know it says there, don't wear contacts. I will bet my license that no contacts, no anything plastic. What? I will talk about it in a minute. But see, I'm already excited about taking the boards for you. Bioresult for infants with heart. It's not used prophylactically due to serious side effects. So we use it as an acute management right now for the RSV. It's administered via droplet aerosol mist with a child in a mist tent. Contraindications, of course, you can't do it. You can't be the nurse if you're pregnant because it's a teratogen. It can harm your baby. Childbearing, you are like me, 28 years old. I'm still childbearing. What? 35 in the U.S. Pregnant or using contact lenses because the mist, the nebulizer, what the heck? The nebulizer that you do on the baby will degrade the plastic. That's why when we do this IV, what kind of container should be used? Glass containers. We don't put it in a plastic container because it will just melt, if you will. No contact lenses, no anything plastic there. The bottles. I mean the plastic bottles. So that's your ribavirin, a very good medication, common one we use out there. We also have Respigam IV for high risk infants. So what's the things that we do when nursing alerts for the board exam? These are, I just put the nursing alerts there and the ones that we have to remember. Otherwise, it's a long book to read, right? Okay, so for our complications, they would have wheezing. I mean, everybody on this recipe anyway may have wheezing, and they may have an RAD, reactive airway disease, which means that if any future attacks, any future allergies or exposure to an allergen, they could have the same scenario, going back to the previous page. So they have a reactive airway disease. Okay, so that's your RSV. The one in your notes, this one is not in your notes, I believe. You don't have pneumonia there. But I checked the bank, it's in the test, so you have to add it. And since we did pneumonia already in term 3, you would have to read this on your own, but I have a few things to say. So, we know it's inflammation of the lungs. We know surfactants are affected. You know the surfactants that have the alveoli that carry the ox and the oxygenated blood where they have the exchange. Okay? So, pneumonia, please review again. They have shallow breathing. It could be primary or secondary pneumonia. Naturally, primary is from the lungs. Secondary is caused by something else. It could be viral or bacterial. Between the two, bacterial is more dangerous, is more fatal. Chlamydia, a common cause of pneumonia in infants, 3 weeks to 3 months of age. And then we have several types of pneumonia here on pages 584 and 85. So I guess we just need to kind of briefly remind ourselves what aspiration pneumonia means. You aspirate something, right? So since we're in pediatrics, which age group of children would commonly be a risk for aspiration pneumonia? The ones who are not swallowing properly yet. Of course, it should not be the school-age boys anymore. 1 to 3, the toddlers. Because especially they put a lot of things in their mouth. Do you remember what Freud said? Freud. The first stage was oral stage. So it goes back to chapter 15 to 20. You review the stages according to the theorists. Okay, so the oral stage. And then you have the lipid pneumonia. Lipid pneumonia, of course, lipid is fat, which is less common nowadays because we don't give a lot of oil-based substances. As I said, I'm 28. Has anybody ever tried, thank you, Kevin, ever, it will be in the test bonus, it's Joe's age. Have you ever were you ever given as a child of my age, Scott's emulsion? Scotch emulsion? Scotch emulsion. We hated it growing up. It's so stinky. It's made from fish. It's fish oil. Yeah, fish oil. But it's so stinky, yucky, gray thing like cement. But the odor is so bad, but very good, right? But that was our nutrient growing up. The heck, I hated it. It tasted so bad, smelled so bad, but this is good for you. Drink it. And that would have caused more lipid pneumonia because it's oil. The point of my story, our book even says it's less common nowadays. I don't see that anymore nowadays. I don't know. My parents were...
You never had tiki-tiki like that?
Tiki-tiki kumbantrin kontrabulate? Kontrabulate. Yeah, burate? Alright. But we don't... Nobody has ever... You know Scotch emulsion? No? Nobody? Victoria.
My mom.
Really?
Yeah, because it was water there, so for the nutrients, they give this.
My mom gave it to us. My mom gave it to
But
us. God, that was the worst ever. Vitamins. Alright, so we know it's aspiration. How come this is here again? Something happened to me in aspiration. But it does make sense. I could have just put here immobilized clients. Oh, okay. Redundant, but makes sense. Okay, so please know the pneumonias, alright? And then I need you to look at the... No more. This is the end of it. No more slides from now on. It still needs to be... Yeah, it needs to be edited. Okay, for the... Ready? Manifestations. They will definitely have in the test bank. Remember, if it's URI, we look for the color of urine, right? If it's respi, we look for the color of the sputum. So what's the color in respiratory, in pneumonia? What color is sputum? I need the exact word, the exact definition color. What? No. Nope. Nope. Starts with letter R. Thank you. You're really rusty. I'm not zero today. Rusty colored sputum, which is brownish, kind of like copper color, but the common word that we use is rusty color. It's kind of like hematuria. You cannot just say reddish. It has to be hematuria. So for our respiratory, we have a rusty colored sputum. They have an infection. First in pneumonia, the cough is dry, but gradually becomes productive. So when you see productive there, that's going to be your rusty colored sputum. The fever is up, and then to compensate, always the heart will be tachycardic. So a classic sign of pneumonia will be tachycardia, tachypnea, tachy-tachy. You tachy-tachy, not tiki-tiki, okay, Alex?
Yes.
Tachy-tachy. So tachycardia, tachypnea, they have a fever, and if they ever have a cough, it's going to be rusty colored cough. And they have sternal retractions again. Our diagnosis, we're going to go for x-rays and WBCs, but definitely in the very bottom, throat culture, the sputum specimens, the throat or the sputum. Our treatment, very easy. They have a fever, something for fever on the top of the book. Antipyretics. They're short of breath, give them oxygen. Right? They have an infection, give them an antibiotic. On the second paragraph, it's common sense. You're going to give them rest, fluids, cough suppressants. And then in the middle of that paragraph, you would avoid smoking, stimulants, and give them a shot of what vaccine? Hib. Okay, so it's really a straightforward disorder, which we already covered in term 3. But you might find page 586, 87 helpful. You have a pictorial, in other words, pictures. So pictures of the things that we usually do for a child with pneumonia. So it's a good one. I marked it. Let me mark it. Do you have Miss Catherine? Miss Lina? Highlighter, the thin one. Yellow. Yeah, because mine's black. I want the thin one. Not like that.
Severe.
I know what I want. And I go for what I want. Thank you.
So bad.
Suzette, are you choking? Are you okay? All right, next is, what's in our notes? In the bank, I see tonsillitis. Your tonsillitis in your, there is, right? You know what, there's a lot. Maybe we'll just have the unit test next week.
Yes.
We're still in recipe. It's already 1, 2, 4, 6. What?
I know.
That's why I said it's a lot. It's not a lot. All right, so we do. Tonsillitis. Read on your own. Let me remind you a few. Let's go with your notes then. Are you okay, people?
Yes.
Okay, so tonsillitis, inflammation of the tonsils and the adenoids. So, the symptoms include difficulty swallowing and breathing. So I don't memorize that because I know 1 to 5 they have difficulty breathing and swallowing. So all of them I group together, right? But once they have difficulty breathing and the tonsils are swollen, a lot of times they open their mouth, so they're mouth breathers. They open their mouth, and so we always watch for dryness in the mouth. I'm on page 5 and 7. So our nursing management will involve, I know it's not on treatment yet, but it's on top. They just put the nursing management there. We have to have the vaporizers. We can suggest the water, the sodium saline water gargles, or even a lozenge. So you can read this, is very self-explanatory. You can even give Tylenol for comfort and then antibiotics if there's an infection. But we do want to focus on the board exam. For the board exam, they always ask the tonsillectomy procedure. Now we know that in term 3 we said we don't normally do tonsillectomy on everybody, right? Unless it's recurrent. So it's happening all the time. That's the time we get the tonsils out. So on the tonsillectomy here, we need to pay attention that this is a child. So in the bottom of the paragraph, you should have age-appropriate explanations. And for example, if you flip to the next page, we don't tell the child you will be put to sleep during surgery. Because for them, put to sleep means dying, right? When the dog is put to sleep or their pet is put to sleep, that means they're not going to wake up anymore. But in adults, maybe put to sleep is just anesthesia. So what is our priority here? Explaining it using age-appropriate discussions or words or statements. So that's one. Another thing for the board exam on the tip there. Anybody who has a throat surgery, we watch for frequent swallowing, right? So we know that. So I'm just reviewing. This is just a review, this chapter, by the way. And then on the post-op, you would see that we position the child on the side. Yeah?
Yes.
Right? And then right below that, you watch for bleeding, respirations, restlessness, and then you would see their frequent swallowing, which is a sign of bleeding on the throat. And to prevent that, we can even put an ice collar. Yeah? Ice collar around the throat. And then right below it, watch for a red or brown colored emesis. That's why we also want to avoid red or brown drinks. Right? We remember this from recipe. And if you were to put, let's say there's no ice collar, but they tell you you can give a popsicle to the child. Is popsicle good?
Yes.
Because it's cold. It has to be not red, not orange. Vanilla flavored would be okay. We know this. I don't have to explain to you this. I need you to read the post-op care. Coughing, clearing the throat, blowing the nose, initially are initially are avoided. I say initially because later, when it's healed, they should be able to cough and expel the sputum. Right? Hemorrhage is the most common post-op complication. We know that. And then the last paragraph, written instructions should be given to the parents about the care. For example, the child may take naps. Yes. You could give Tylenol. Yes. How about the last 3 lines? Gargling and highly seasoned food should be avoided within the first few weeks. And last but not the least, in the very bottom, we don't like milk in the acute post-op, right? Because it will cause more sputum. Very good. So that's your tonsillectomy. Now we have asthma. Okay? Okay, pasok.
Nothing at all.
Nothing. Asthma. What is asthma? They describe it according to... How come I have SARS? Is SARS on my test? Is SARS in your book? Oh, sorry. You have to... Sorry. SARS is... Sorry. 585. My bad. This falls under pneumonia. This is the complication of pneumonia. Okay, so we just read that last paragraph. The reason why I included it was, if you remember, about 3, 4, 5 years ago, SARS was
An epidemic.
not quite. Was it an epidemic in the U.S.?
was a lot of cases.
Probably not in the U.S. though. Other countries, no. So, and we were afraid that it was going to enter the states. You remember those people getting off the plane and they had masks, and they also, of course, stereotype Asians. You people, you go home to your countries. I did not travel that time because I was kind of, thinking. But anyway, this should fall under 585 under pneumonia. Okay, so we go to asthma again. We did this in term 3, so I need you to review. This is like, I think on this page is about 3. This is the longest. 3 pages just for asthma. The rest were like 3 paragraphs. So asthma, you would know, then there will be more questions in the test. So let's just pick up some things. I cannot lecture asthma in 30 minutes. We lecture this in recipe in 1 day or something. So left side of the book under asthma, it'll just tell you where it came from the Greek word, blah, blah. I don't care really. But the bottom is what I care about asthma. There are 4 conditions that will appropriately, or if I just look at these 4 conditions, I can already answer most of the questions in the test. 1, I know there's bronchospasm from the closure of the irritation of the airway. I have inflammation and I have the airway hyperactivity, and there will be mucus. So those 4 are involved. So then I go straight to the right side of the book. So that's the first one I need you to look at, the 4 conditions involved in asthma. And then the right side of the book on top, I know that there are contributing factors. For example, the 3rd line, you would have there the triggers, the house dusts. Well, it doesn't have to be in the house. It can be outside. Animal dander or hair, wool, feathers, pollen, etc. Smoking, anything that can trigger the asthma, even a fume or a wet paint. Self-explanatory, right? So you'd have there the contributing factors. Right below that, a few lines below it, even emotional upsets can trigger the asthma. And then right below that, you have environmental. So you just categorize them. It could be the environmental, it could be emotional, it could be the allergies. And then below it, before you end that paragraph, about 5-6 lines from the bottom, you would see there PCO2 rises and the pH falls. That's why a common complication of asthma is respiratory acidosis. And children who are prone to allergies, that's why you have allergic asthma. Let's just review a little bit, just briefly. Do you remember that asthma could be intrinsic, extrinsic, or mixed? Oh, yeah. Intrinsic is, it starts in the inside. So that's where, when the babies are born, they may have the asthma problem. Extrinsic is more of the allergies. And then mixed is a combination of both. So it's really very, if you just remember the intrinsic is that thing that is coming from the insides, like primary asthma. Extrinsic is the one that you have to avoid the triggers, the smoking, etc. So intrinsic, extrinsic, and then mixed is the third one. So let's diagnose the baby, the child. Let's do a history, physical exam, bronchodilators, response to bronchodilators. I numbered my books. So my number 1 is history, my number 2 is physical exam, my number 3 is response to bronchodilator, number 4 is elevated eosinophils, number 5 is sputum test, number 6 is allergy test with a RASP. That's the reason why I numbered it, so is that when I refer to it, I just say the number. So my number 4 and number 6, what were those? Elevated eosinophils and RASP. Those 2 tests are specific for the allergic type of asthma, which was the extrinsic asthma, right? 4 and 6, number 4 eosinophil and number 6 RASP. Those are the tests that we do for allergic asthma, which is also called extrinsic asthma. And number 7 on the list of my diagnosis is exercise testing and pulmonary function tests. Right, they let them exercise a little bit and see if they're wheezing. Do you remember the pulmonary function test? We're sitting in the boards right now. Question number 85. What's the most important? And this is, we're sitting in the boards. There's 85 questions minimum, right? And the boards will either shut down at 85 or give you 205. Which way do you want to go? 85. I think I will stop at 85. Most Marian graduates, by the way, stop at 85.
Wow.
Or 86. 86 is so stressful. No? Don't stop at 45. Computer will give up. The minimum is 85. Computer stops at 79. Can't take it anymore. Okay, question number 85. What's the most important instruction that you would give to a child or adult scheduled for a pulmonary function test? What to expect while there? What instruction? What should they do when they sit there on the pulmonary function test? What should they expect? Okay, how is pulmonary function test done? It sounds nice. It's a nice word. It's a nice test. Pulmonary function test. You're going to go for a pulmonary function test. What the hell is that? Okay, Tams. This is board exam. Question number 85. Okay. You don't want them to eat? You don't want them to be too full? Yes, they could eat a little bit. Okay, let's hear you. What they would what? Blow on a thing and then? That's a good one. That's actually what they do.
Right?
Blow on the thingy. Told you, Alex. It's called thingy.
There's like a scale, right? Like a...
They will measure how much air, but the most important thing, yeah, you're right. Okay, you pass, no removal for you. 75. They blow on the machine, the PFT machine. But the most important thing that they have to anticipate before going there is to tell them their nose will be clipped.
Oh, yeah.
And then after that, they'll be so tired. Exhausted because they exert everything and it's... No, these are board questions. PFT, you have to tell them your nose will be clipped, and you'll be blowing on those tubes, and after that you may feel a little dizzy, a little tired. We don't ask any, out of this world questions. We ask nursing instructions and patient teaching. So that's what we will focus on here, on the last one, the pulmonary function test. On the bottom, page 589, before we flip the page, would see on the manifestations, third line, obstruction is most severe during expiration. That's why the kind of wheezing we see in asthma is expiratory wheezing. When they expire, when they exhale out. Okay? And then in the very bottom, then we go to the next page. Another thing that we already talked about is acidosis. They will have acidosis. And then now I'm on the second paragraph. They have a cough, they'll have wheezing, they have difficulty breathing, they have signs of hunger, which could be manifested by flaring nostrils. These are all term 3 lectures. They would have orthopnea. You know what's orthopnea, right? Okay, same. Next paragraph. If the attack happens at night, this is frightening and scary for the parents and the child, right?
Yes.
So can we have this child in the bathroom with a hot shower open for easy
Yeah.
breathing?
Yes.
Sure, why not? Same thing as a croup. Yes? For chronic conditions, this is a common board question. You look at the child, they have what we call the allergic shiners. There's coloration under their eyes. I just think of it as someone, even if you're an adult, if you don't get to sleep good at night, you have a bad night, you have insomnia for 5 days, you're going to have your black eyes, no? Under the eyes. So,
Bad.
panda eyes. So also in children, they're always awake at night. They have difficulty breathing. They may have that what we call the allergic shiners. Okay, for our blood test, it may show eosinophilia because we said earlier the eosinophils will be elevated, right? It's right here in the bottom. And we're going to do pulmonary function test again. I need you to review the treatments. They always ask for the treatments and they're always I don't know, it's kind of predictive. You already know what they will ask. First, on the treatment. The first treatment is rescue treatment,
Oh.
right? Immediate treatment. The second management is maintenance. So, on the table, just look at the common medications that we use. And I'm going to go straight to the ones that you see commonly, daily medications. Do you see that daily medications? Since it's called daily medications, they're not the rescue medications, right? Rescue means ER medications. Daily medications are your maintenance meds. For example, have you heard of salmeterol?
No.
Nope, but that's a cousin of... Which one? This one? No, these are the cousins of your... do you remember Intal? Formalin sodium. This is a term 3 lecture. But both of these look at the salmeterol and the cromolyn sodium, the mast cell inhibitor, which is your Intal, which has a cousin Singulair, and a cousin Solair, and the cousin Zaffer Lucas. Hello? Yes? No? Yes, it's expensive. Yeah, it's very effective. But these are daily meds. And if you look at the nursing considerations, just look at the one, cromolyn sodium. It's very common that you see in the hospital. Cromolyn sodium, 1, 2, 3, 4th line of the daily meds. Do not use during acute episode. Why? Again, because these are not rescue drugs. You will have to take it several times